Good evening, everyone. Welcome to our webinar for endometriosis. It's the first from Cromwell Hospital. Endometriosis is a condition poorly understood that affects millions of women worldwide. And today will be a panel of experts to talk about endometriosis in detail. My name is Amir Raza. I'm a consultant gynecologist and endometriosis lead consultant in Cromwell Hospital. I'm a robotic endometriosis surgeon, and I do my research in endometriosis in Chelsea and Westminster Hospital. We are incredibly fortunate today to have a panel of distinguished experts in the field of endometriosis. These specialists have dedicated their career in gynecology, women's health, and are specifically helping patients with endometriosis. I will introduce them from my right side, Mr. Valerio Celentano. Mr. Valerio Celentano is a colorectal specialist with a special expertise in inflammatory bowel disease, which is a very complex part of colorectal care. But he developed interest in endometriosis many years ago, and now he's one of the finest consultants when it comes to bowel endometriosis. We have been working together for many years, and it's absolutely a pleasure to have him here on board. Thank you. Thank you. My other side, right side, is Maya Al-Mimar. Maya Al-Mimar is a consultant gynecologist and lead consultant for adolescent gynecology in Imperial College London. Adolescent gynecology or endometriosis in young people is a very challenging issue. And we are very fortunate to have Maya here, who is not only a gynecologist and expert in adolescent gynecology and endometriosis, but also a fine ultrasound scan expert who has done higher degrees in scanning and diagnostic capabilities. We have on the left side, Denia. And Denia is our clinical nurse specialist, who is, if you look at the endometriosis care, it's like lots of people, and Denia sits right in the middle of it to arrange and organize everything. So her role is absolutely pivotal in any complex endometriosis care. So we're very fortunate to have her here and join us in this panel. Then we have Mr. Pavlos Pavlaki. Mr. Pavlos is sitting somewhere in the sunshine in Greece, and very fortunate for him to join us now. Pavlos is an accomplished robotic surgeon in urology. He has done his robotic master's and expertise and PhD from Sweden and Paris, and now he's managing complex urology problems such as bladder cancers and ureteric abnormalities in robotic surgery. And we are fortunate to have him on our endometriosis team because, as we all know, that how endometriosis can have an impact on ureters, bladders, and kidneys. So having an expert like him on board makes this very complex disease manageable. Thank you. And we also have with us, Herod with us, who is sitting in the background, making sure that all the technology works well. So at times we may have to ask her to come and help us. So we will start our discussion now. The way we will do it now, that I will start talking about endometriosis and the challenges we all face. I'm sure many of you sitting here will be either patients or one of your loved ones will have this problem, or you will be interested in this disease. I'll be going through some fundamentals of endometriosis, and then we'll ask my all colleagues with expertise about relevance of endometriosis in their subspecialty, and then we'll come back to question and answer. We've already received many questions, and I'll try to answer all the questions. However, if time didn't allow us, then Denia has promised me that she will be answering all the questions, and they will be on the website as well for you to see. Endometriosis, the simplest definition I can do is a tissue resembling the lining of the womb, growing outside the womb, attaching itself to the other pelvic and abdominal organs, causing inflammation, scarring, and cysts. This is the simplest way we can define this problem. It's the most common disease, but you have never heard of. At least 1 in 10 women suffers with pelvic pain and its problem. And if we look at the total number in a In the world, it will be 250 million and possibly more if we take the higher number of the endometriosis people in prevalence, about 500 million. There's no diagnostic test for this disease, which is so common. We do not have any cure if we diagnose someone with endometriosis. It affects from simple quality of life issue to very severe problem in fertility. And not only this, it is not a disease which is affecting one organ or one thing. It goes on to impact on so many different organs in the body. And again, if from superficial to deep disease, it has huge implication for our body. If we continue with this challenge we all know, and I'm sure many of you would have read it, there's a delayed diagnosis of 7 to 9 years, even if one has been going to their GPs and specialists. Infertility is affecting over 20% of the people. And in spite of all the challenges, we have lack of awareness and lack of research, even though this problem is so common. So if I take all these things in this one few words to summarize them, it's like etiological confusion. We do not know where this disease is coming from, and then how to treat it, therapeutic anarchy. So we really feel ourselves sometimes lost that what's the right way should be. Now, I'm not going to take you through all the slides. There's a lot of different slides, but just give you a taster. There's so many reasons, so many causes that why endometriosis can start. There's not one simple mechanism by which I can say this is the cause of that endometriosis. There are many theories, and these can explain endometriosis in different ways. Either it's a theory where cells can go outside the uterine cavity and adhere, or it could be an estrogen dominance, or it could be at cellular level. We may have infiltration, proliferation of cells due to increased natural killer cells leading to tissue injury and repair and fibrosis. Or we can talk about other inflammatory cells, genomic alterations, epigenetic theory. I mean, I can keep going with different fundamental immunological and inflammatory response to the body, that how it keeps on growing from one tissue to another tissue, jumping from one organ to another organ, creating a huge problem and indeed causing massive issues. Even immune regulation that can become abnormal in this disease and lead to endometriotic lesion. And all these different way of explaining things, etiologies, then takes us to how patients presents to us. And if I put it in a simpler word, it's a symptomatic storm. Yes, it could be a very mild pain at one end of the spectrum, but the other end is a pelvic pain, excessive cramps, is pain with bladder, urination pain, bowel issues, constipation, nausea, abnormal heavy menstrual flow. Fertility becomes a huge issue in about 15 to 20% of patients because it's a disease in young people. Mostly people will come to us between 20 and 40, even though it can happen at any age, which Maya will tell us about a young age, and even we see people at the older age as well. Pain during intercourse, vaginal bleeding, fatigue. So in brief, it involves so many different organs of the body causing problem. And if we look at the etiology, and that's where the challenge comes from, given that it involves so many organs, gastrointestinal, gynecological, urological, musculoskeletal, even psychological, but sometimes we forget that when someone is suffering with so many problems, it becomes a huge stress and anxiety, and even makes it difficult to cope in everyday situation. So this disease is not a simple gynecological thing. It's far more than that and far more complex. And the challenge comes obviously for GPs and doctors, how to identify that one patient who is suffering with this problem. And that's, I think, where this webinar comes as well. Management of complex endometriosis. It is not one person can do everything, or one expert knows how to manage it. Absolutely not. Because disease is affecting so many organs, it has to be multiple experts come in one room and talk about every individual patient and come up with a plan. Gynecologist, bowel specialist, urology surgeons, radiology were expert in finding the endometriotic lesion in MRI scans or ultrasound scans, chronic pain team, physiotherapist, psychotherapist, nutritionist, dietitian. It all has to come together to manage this disease. I mean, in this room, you see 4 of us sitting here and Pavlos on the line, but actually we cannot even put people in one room. There's so many of them involved in care of one patient. But I believe this is just the start of our webinars, and I'm sure we'll bring in more experts as well who are very key to the management of endometriosis. Given these challenges of diagnosis and the treatment, there's a huge amount of research. I don't want to give an impression that it's all doomsday scenario. Absolutely not. Many things are happening now, which are research is moving forward to see how endometriosis starts and how it can be treated. Scotland, Leicester, many other big research centers in Chelsea and Westminster Hospital. There are many research projects now going on, which are almost getting to some kind of conclusion as well that what's causing the problem. It is just giving you a brief view that how different research projects are running. Regal study, Diamond study, and the studies now, and the SAFE study for endometriomas is coming, which are helping us with all this problem. So the work is still going on. As we move this discussion further and come up with a question, we'll come back to surgery, treatment, various treatment options, the new advances in the endometriosis treatment. But we would like to hear at this stage now from other colleagues who are here and to have their expertise. So very pleased to invite Ms. Maya Al-Mimar from Imperial College London to tell us more about adolescent gynecology and adolescent endometriosis. Thank you, Maya.
Thank you so much, Mr. Raza. It's so lovely to be here with you all this evening. And I hope really what comes across today is how passionate we all are in trying to support women with this condition. What kind of qualifies me to speak about adolescent women really is because I'm lead for paediatric and adolescent gynecology, as Mr. Raza said, at Imperial. And you'll find more information about me if you'd like on the website. But in essence, painful periods in adolescence are actually really very common. And there's increasing evidence that this hugely impacts quality of life, with significant disruption to school and activities such as participation in sport. So this can be a real problem for young women. Reassuringly, with painful periods, serious pathology is actually quite rare. But the real challenge is that most research in this area is based on adult women. And the big question is, can we then really translate all that research in this group of patients? And that's the big question that has not yet been answered by research. Sorry. It's quite sensitive. So why can periods be painful in adolescence? Well, when your periods first start, the hypothalamus, which is the part in your brain, needs to communicate with a gland in your brain called the pituitary, which then communicates with your ovary and then your uterus. And essentially, this process of communication can slightly be less mature when your periods first start. And therefore, most of your cycles initially when your periods start are what we term anovulatory. What that means is that you might have cycles without releasing an egg from your ovary. And what does that really cause? Well, it causes heavy, prolonged and painful periods. And we very commonly term that primary dysmenorrhea, which is a very fancy term meaning painful periods but without a serious underlying cause. That itself is really common and over time tends to resolve. Now, then there's the other group of patients whose pain doesn't resolve. Their pain might persist, become worse, or they develop other more worrying symptoms. They can be resistant to hormonal treatment. And this makes us start to think, well, is there any other cause for painful periods in this young person? And that is termed secondary dysmenorrhea, essentially meaning painful periods related to another gynecological underlying cause. And that might be something like adenomyosis, which is a condition where we find cells of the lining of the womb in the muscle of the womb, or congenital variations in the development of the womb, which most commonly present in adolescence, or the most common cause of this is in fact endometriosis. The challenge is we don't really know the true incidence in adolescence, and the reason for that is we really need to be doing keyhole surgery and lots of young women to understand that better. And there's real conflicting data in this field, with some groups and researchers believing that endometriosis in adolescents is very, very common, and others believing that it's actually more rare and takes time to develop as you get older and more hitting your late teens and early 20s. And so, however, taking that all in, exactly as Mr. Raza said, well, how do we differentiate? How do we know the difference between those people who have a benign, no worrying underlying cause to their horrible periods and those who have a condition such as endometriosis? Well, really, this is how I would approach it in the clinic. The first and the most important thing is your story. And we spend so much time in our clinics listening to your stories. And often because sometimes many of our patients who eventually come to see us haven't been given that opportunity to share that. And I think that's really, really critical. And one of the important aspects of that is really understanding how your symptoms are impacting your quality of life. The other that's really important is looking at lifestyle. And perhaps some of my patients think I'm a bit eccentric, but I will ask you what you had for breakfast, lunch, and dinner. I will ask you how much water you drink and also what exercise regime you're doing. And that's really important because this is going to help us try and find the best management approach for you. It might also involve an examination, and for some young patients that I see, and I often see very, very young girls, it's the first time they've seen a doctor. So we have to do this in the most sensitive manner, and it might just involve feeling the outside of the tummy and maybe taking a blood pressure check. Very simple bedside tests. That then leads us to investigations and what tests one might do to assess the reason for painful periods. Now, on the whole, ultrasound is actually very good at diagnosing endometriosis, particularly in quite expert hands. However, this tends to be using a transvaginal ultrasound scan. What that means is doing an internal scan. Clearly, that's not always appropriate in a young adolescent girl, and therefore we would look to do a transabdominal scan, which can help diagnose endometriosis if you have, for example, a very big endometriosis cyst. However, if you have a normal transabdominal scan, that does not exclude the possibility of endometriosis. Sometimes in those with quite significant symptoms, we might worry about very significant endometriosis disease and arrange an MRI scan, which can help. But again, it's really important to understand that a normal MRI does not necessarily completely exclude endometriosis. And the only way to fully diagnose endometriosis is to think about having keyhole surgery. But clearly that's not appropriate for all women to have an laparoscopy. If there is any worrying findings on scan or any need or any complex aspects to symptoms, we might consider using the Cromwell MDT to discuss your case. And of course, the other really important thing to know about, particularly in adolescents compared to older patients, is that other conditions are really common that can cause pelvic pain. For example, bowel conditions or bladder conditions. So it's really important to consider the need of the input of other specialists. And we're all very lucky here because we get to work together and refer and discuss our cases through the MDT. Based on all that information, we would then arrange follow-up, and really we work together with you to agree the best management strategy. Now, then the question is what if all your tests are negative? Does that mean you don't have endometriosis? Well, it's again, like I said, it's so important to know that the best way, even if all the tests are negative, is to think about having a keyhole surgery to diagnose endometriosis. However, having said that, that might not be appropriate, and of course keyhole surgery comes with risks. It's also important to notice that sometimes you can have very horrible periods, but have a negative laparoscopy. What I mean by that is you don't have endometriosis at laparoscopy, at keyhole surgery. Now, it's really important for everyone here to know is that that does not mean that your periods are not painful. Your periods may be painful, but we can't always explain all pain. And that's why it's important to think about how best to help support and treat the painful periods, but of course endometriosis if that is the final diagnosis. Now, the aims of the treatment is really looking at symptom relief in young girls, particularly to allow for improvement of quality of life, school attendance. My big bugbear, participation in sports, because it's the commonest time young girls stop doing sports is because of their periods. So that's really, really critical. And we often talk about symptom relief and using hormonal treatment to aim for a holiday periods, so term time aim for having no periods using hormonal treatment, and the reason for that is to improve school attendance and disruption to schools. That's so critical. We talk about also the possibility of using treatments to potentially protect from future fertility and suppression of disease progression. I put a question mark there, and it's really important because one of the challenges in endometriosis and endometriosis research is we don't know the long term and the natural history and how endometriosis behaves in the long term. And we can't always predict those that will go on to develop severe disease and those whose disease will remain stable. The key to treatment is that we really individualize it to you. We want to work with you to decide together what would be the best way of managing your symptoms. And that really decisions are based on your choice, the potential need for contraception, even that might be in young adolescent girls, any potential contraindications to treatment, and of course, fertility aspirations. And in essence, this bubble of surgical management, medical management, lifestyle and support is not that one thing is better than the other. It's thinking about all the four combined and how best we can support you. Surgery plays a huge role in diagnostics and treatment, but we have to acknowledge that endometriosis is a chronic condition and there is a risk of recurrence. There is often a worry and reluctance to start medical hormonal treatment in young adolescent girls, but I really want to reassure you that this is a very, very good and safe way of managing difficulties with periods when you're young and provides long-term hope for protection from progression of disease. Really important to look at lifestyle and particularly looking at diet and exercise. And the other thing we have to acknowledge is that this condition, because of its impact on your quality of life, can have a huge psychological impact, as Mr. Raza explained. And it's really important to look at peer support. And there are wonderful charities out there now, Endometriosis UK and others, where who can provide you with that peer support and online information, which I think is really important. I just wanted to have one slide looking at nutrition, and I do think this is really, really important because there is increasing evidence of the role of your diet in all different diseases, whether it be colorectal, urological, gynecological diseases. And actually, although the evidence base is weak, it does exist and is becoming stronger. Now, what we don't know as yet is if we change our diet, could we change our symptoms? Could we change and alter disease? But actually, there is evidence enough to know that this could help your symptoms, and that's really, really important. And there are really three types of diet that have been shown to help with endometriosis symptoms. The first is anti-inflammatory diet, and what I always tell my patients is please eat the rainbow. So you can look it up, the rainbow diet. We don't have so much time to go into it, but this is really important. Eating 30 different fruit, nuts, vegetables, seeds per week, and encouraging diversity in your diet, which is so critical. I did a lot of research in the microbiome, which is bacteria that lives in our bodies. My area of research was the vaginal microbiome, but really critical to know that the gut bacteria and supporting a healthy gut bacteria is critical in managing pelvic pain and endometriosis. So this is about looking at eating foods that are rich in prebiotics and probiotics. So fermented food will give you lots of probiotics such as kefir, kombucha, sauerkraut, all of those types of foods. And of course, there's the foods that support estrogen metabolism, so your soya beans, your lentils, your black beans, all of that. This is really critical. And this is not to say that this is the only answer, but it's really important to look at the management of this condition in a holistic way, and that there isn't one solution. It's critical that we look at surgery, medical management with hormones, look at lifestyle, but also look at peer support. And this is what we're really here to do. And I hope you found that overview quite helpful. Yes.
Thank you very much, Maya. Everything you said is absolutely applicable to all the adult patients and everyone actually. So very helpful, fantastic talk. Now that takes us to our esteemed colleague, Mr. Valerio Celentano, who is a bowel specialist. And when it comes to bowel endometriosis, I cannot find anyone better than him to be with me in theaters in those very complex bowel endometriosis cases. So Valerio, please go ahead.
You want to exit the presentation? No, I just wanted to say thank you all, first of all, for joining us this evening. And I would like to extend my thank you to Mr. Raza and Cromwell Hospital for putting together such a center of expertise for caring for women with endometriosis. As we've heard, it's extremely important that patients who are investigated and treated for endometriosis receive their treatment in specialized centers where a lot of expertise is available. You heard that endometriosis is a condition that can be quite unfriendly sometimes, unfortunately, and affect different organs. So where in the MDT we will review the results of patients, like perhaps some of you that are online tonight that already had an operation or are considering to have an operation, we will see that there is a need sometimes to involve more than one specialist in the operation. And as bowel surgeons, we get involved in approximately 1 patient out of 5 who has surgery. So bowel involvement in complex endometriosis tends to be quite common. And one of the problems, in case you decide to go online and Google about some information about bowel surgery for endometriosis, is that a lot of the information that you will find is actually not related to bowel surgery for endometriosis itself, but it's related to bowel surgery for another more common condition for bowel surgeons to treat, which is bowel cancer, which is treated in a very different way compared to endometriosis. In endometriosis, what we want to do with surgery, and hopefully this will come across from some of the nice cases that Mr. Raza will be presenting tonight. What we want to do with bowel endometriosis is to be as protective as we can of the healthy bowel that you have on the inside. So whilst when we do a bowel cancer operation, we will want to remove a large portion of the bowel, which is widely healthy around where the bowel cancer is. In endometriosis, we only want to remove those particular nodules on the bowel that are causing a lot of problems, like narrowing in the bowel that we call strictures, or they are causing different organs to stick together, which is what endometriosis does. So one of the most common areas for bowel endometriosis to be is in a nice healthy space that sits in between your gynecological organs at the front, the vagina and the uterus, and the bowel at the back. This is called the rectovaginal space. Normally, these two organs are quite far from each other, but endometriosis makes them become a bit too friendly to each other. And this means that when we do that, and this often reflects in patients having loads of bowel symptoms, pain, problems with constipation or diarrhea. And when we do surgery together with Mr. Raza, we need to separate these two organs, assess the bowel, and check for all the spots of endometriosis that the MRI scan has suggested. And then, if possible, our preference will always be to leave the bowel as protected and intact as possible. And we will apply the treatment that Mr. Raza has often discussed with you that is called the rectal shaving. So shaving is a very intuitive wording. What we're doing, we are trying to remove just the outer external layer of the bowel wall, keeping the bowel itself protected for any damage. Unfortunately, what happens sometimes is that the MRI scan, and when we repeat the assessment during the surgery, demonstrates that the endometriosis start putting some roots deeply inside the layers of the bowel wall. And unfortunately, this means that if we just shave the outer one, we will still leave a lot of endometriosis on the inside. So you will discuss with your colorectal surgeon in clinic that in that particular moment, the option to remove the endometriosis, if it's been agreed with you and with the MDT that surgery is the best way forward, will involve removing those 4 or 5 centimeters of bowel that are affected by the endometriosis. When we do that, a bit like very specialized plumbers, we need to join together the 2 ends of the bowel after the endometriosis has been removed. And this joining, plumbing, stitching we do in the bowel, unfortunately has a high risk of infections. And that's for that reason that we do these surgeries very carefully, and we try every single time we can to avoid doing the bowel resection unless it's really, really needed. And we are very lucky that nowadays we are supported by some very precise and good technology that is called robotic surgery, where we can really, with a minimal invasive approach, without needing to use large incisions and large scars on the abdomen, we can very precisely assess the endometriosis and just peel it off the bowel itself most of the times. Do some very careful suturing on the bowel itself, and also during the surgery we do a camera test of your bowel that we call sigmoidoscopy, which is essentially a shorter version of colonoscopy, in order to check that all the repair that we've done is going to be safe and air and watertight. One of the main questions that I go asked in clinic, but I think pretty much every single patient who comes to see me in clinic for endometriosis surgery will ask me this question many times, because obviously has enormous implications for patients, and there is a big fear around endometriosis surgery affecting the bowel, and has to do with the stomach bag, something that I'm sure some of you would have read about regarding colorectal surgery, bowel surgery in endometriosis. And a stomach bag essentially means that rather than going to the toilet normally, for a few months, the bowel content will have to be diverted out of the bowel in order to protect all the plumbing and stitching that we've done. Now, stomach bags are rarely the first choice in endometriosis surgery. We tend to do them quite rarely. In our case series, having a stomach bag for 3 months only happens only to 1 patient every 100 of all the patients who have this very complex endometriosis surgery affecting the bowel. And we will do all we can in order to remove the stomach bag 3 months later with a much smaller operation. But as you can see, there is quite a lot of decision making and counseling that that surrounds the endometriosis diagnosis and the decision to have surgery. And I think this really highlights, the importance of having centers of expertise where on the same operation you can benefit from different experts. Because one of the problems we tend to see quite often is that unfortunately the endometriosis procedure was incomplete, the result was not satisfactory enough, just because all of this expertise was not considered, was not involved. So hopefully you will see later how much discussion and complexity and decision making there is behind the scenes before offering an operation. Thank you.
Thank you very much, Valerio. It's very helpful, and I'm sure there'll be lots of questions to be coming your way as well as we move towards the discussion. So it's a time now to ask our good friend and colleague Pavlos Pavlaki, who is an expert robotic urology surgeon and part of endometriosis team. We know that kidneys are in the loin up area, and the ureter's 2 tubes come from the kidneys into the bladder, almost hugging around the uterus. So whenever it's endometriosis and extending out of the uterus into the organ, ureters and bladder are one of the very common organs which get involved. And managing these complex areas is really, we need to have a multidisciplinary approach, an expert like Pavlos. So Pavlos, please go ahead and
Thank you, Amir, and lovely to be here. And thank you all for joining us. I will try to be very brief and efficient with clear messages. As you know, endometriosis is a multisystemic disease that can affect different systems. From my perspective as a urology consultant, I'm specialized in robotic surgery, in keyhole surgery, and in regards to endometriosis, we see patients that have symptoms that can affect the bladder and the ureter, symptoms that can mimic and present as painful bladder, painful micturition, or kidney colic pain, which means that the endometriosis scar tissue has involved the connection between the bladder and the kidneys in order to create a further increased pressure of the renal function of that kidney that is infected. That's what we say. The kidney has been hydronephrotic because it is blocked, obstructed partially from the endometriosis scar tissue, which is extended outside the bladder, outside the ureters, involving part of the ureter. So my role in this surgery is to inspect the bladder. We usually use a fluorescent dye, which is called ICG, indocyanine green substance, which can fluorescent intraoperatively the ureters during the dissection. So my role is to dissect the ureteral tissue, which is involved and stuck because of the endometriosis scar, and unobstruct the connection between the kidney and the bladder. In very rare cases, I would say less than 2%, I need to remove tissue of the distal end of the ureter, of the tube that brings the urine from the kidney to the bladder, and rejoin the connection. In that case, that means that I will have to make a reimplantation of the ureter, and I will have to do that because the part that is removed is massively damaged on microscopic level. And even if we remove the endometriosis tissue, that means that in further months to come, there is a possibility of a obstruction to reoccur, not because of the endometriosis, but because of poor quality of blood flow on microscopic level. You can show, Amir, another picture which shows the ICG picture, which is the next slide, if you can. I don't have control of this.
Yeah, we can see it now. Go ahead, Thomas.
Okay. So in cases that we do need to do distal dissection and removal of tissue that involves the ureter and make a new connection, which is extremely rare, I need to insert a silicone tube, which is called a J-stent that will safeguard this new connection for a few weeks. Thanks to robotic surgery, we have 3D vision and make a surgery easier for us because we have a very good, precise, and clear vision. I don't want to take more of your time. I just want to deliver the message that endometriosis from the urology point of view can mimic a urinary infection, a bladder painful syndrome, and can be involved into obstructing partially the connection of the kidneys into the bladder. It's something that we've seen many times, and thanks to robotic surgery, we can safely and precise remove the tissue which is involved, and extremely rare time and frequency in cases that we need to reinsert and reposition the ureter in a different site. Thank you very much for joining, and thank you all for being here.
Thank you very much, Pavlos. Very helpful and very clear, succinct message. Thank you. Now that takes us to our good colleague, Dinia Balan, who's a clinical nurse specialist in endometriosis. And really without her, bringing all these pieces together is almost an impossible task. So Dinia, please tell us about your role and how you fit into a multidisciplinary team.
Okay, so good evening, everyone. As what we have heard, all our experts have discussed how complex endometriosis is. So here comes my role is being a member of the multidisciplinary team and make sure to maintain strong links between the team. As what Ms. Maya has discussed earlier, we bring a lot of complex cases during our MDT discussions, ensuring everything is being checked, being discussed, and making sure that we are going to provide the right management to every single patient. I am also the point of contact to all our patients, enhancing their journey, providing an expert and a high quality of care. I provide an independent nurse-led service, including pre- and post-surgical care, and for patients choosing a non-surgical approach of care. And then finally, I am also responsible in maintaining the BSG database for Cromwell Hospital to keep our accreditation as an international endometriosis center. Thank you.
Thank you very much, Dinia. Thank you. Right. Okay. That now brings us to the next stage of our discussion. We're talking about here complex endometriosis, and there's no best way to understand the complexity of situation unless I bring up a case. I will now present a case actually of a difficult endometriosis. And then while all the colleagues are here, like any multidisciplinary meeting we do here very frequently to see how every expert will tackle the disease. So I have a patient here who is a 36-year-old presented with severe pelvic pain, period pains, and she also has a right-sided loin pain. She had an ultrasound scan which showed there's a 5-centimeter endometrioma. Mobility sign was negative, which means that all the pelvic structure along with ovaries were frozen together. She went on to have MRI of the pelvis, which showed she has a rectovaginal nodule, about 4 centimeters in size, which is also invading the muscularis of the bowel. And I will make these things simpler as we go along. She also found to have a right-sided hydronephrosis. So this is the MRI scan. This patient had blood tests for her fertility, and her AMH has come back 9.2 at the age of 36. AMH, as many of you know, or you don't know, is anti-Mullerian hormone. This is one of the most sensitive tests we use to check the quality of the follicles or patients' ovarian response to different hormonal treatments. It is a test which is used very commonly. So if we have this patient now, the question is how we are going to manage this patient. So I think I will take a start from the gynecological end, and then I will move towards Valerio and then going to pelvis now. She's 36-year-old. She has been suffering with pelvic pain, and obviously now MRI scan shows severely deep infiltrating endometriosis involving multiple organs. There are two things in this patient. One is her symptoms and quality of life. And while we're looking at those symptoms and quality of life, second thing we always have to think about fertility as well. These two things go hand in hand. If I have to underline the principles of endometriosis surgery, that principle will be do as little as possible to remove as much disease as possible. So not to do too much, but to do little, but to remove the disease to help the symptom. It's a little bit different from cancer operations, where you want to remove as much as possible, not to leave anything behind. So endometriosis ethos, our philosophy is different. Second thing is, no matter what I do, I have to make sure that the functionality of any organ does not get an adverse impact. It means ovaries function normal as they are, the fallopian tubes are left intact, the bowel functional, and the bladder fine, and the uterus is fine. So no functional impairment should happen to any of the organ as a result of that surgery. And needless to say, and many of you who are now at the forum as well, endometriosis is a disease of young people. And really in young age, all the way from starting from very young age, all the way to 40 and 45 people, it's a disease you want to be very careful when making these judgments, that how it will impact on the quality of life, whatever decision you make, and how the fertility. So in my case, in this patient now, one, she is having severe symptoms. So I need to think about giving her the option of conservative, medical, and surgical. That's just a routine practice and a right practice to open all the options to the patient. And then when it comes to medical treatments, our hands are very limited. There's no one medical solution or tablet I can give it that will help you. We know when we give medical hormonal treatment, which can range from combined contraceptive pill to progesterone, only tablets to Dynagest, and moving on to injection Zoladex and generic analog injection or agonist. These treatments have limited value. They help with the symptoms. And we know that in 50% of the cases, even if we are taking medical treatment, it helps improve the system. The disease still may keep on growing. So all these pros and cons of medical treatment needs to be explored when I'm going for a medical treatment or a surgical treatment. When it comes to surgical treatment, then obviously the most common approach will be laparoscopy, a keyhole approach, and excise the disease. This word, I'm sure a lot of you hear very often, is it an excision, is it an ablation? Now in my practice, and if you look at all worldwide practice in major endometriosis center, the excisional technique, when we remove the disease, is the right way forward. It's like tip of the iceberg. If I see a black lesion in the peritoneum and go and burn it, yes, we have burnt it, but the root of it and the iceberg underneath can be much deeper. So excisional surgery allows us to remove all the abnormal tissue. But again, this excisional surgery then needs to be balanced with functionality of the organ, not causing any harm. And that's the important parameter. So in this case, I think as a gynecologist and endometriosis specialist, next thing will be to proceed to multidisciplinary meeting, which we are doing now, and it will be after discussing all the options with the patient to proceed with surgery. And if I'm proceeding with surgery, Valerio. She has bowel symptoms and muscularis is involved as well. So how will you counsel this patient, and what are the important things you'll be taking care of when you're planning to operate on her?
Yes, for sure. I mean, this is a procedure where multiple specialists like the urologist, the gynecologist, the colorectal surgeon will need to be involved. From the perspective of the colorectal surgeon, we've heard that there is a quite sizable nodule on the bowel. It's 4 centimeters, very likely is causing a lot of symptoms due to pressure, has a risk over time to get bigger and cause even very extreme problems like bowel blockages or causing pain and bleeding during periods. So if surgery is the way forward, during the operation with robotic surgery, we will repeat the assessment that the MRI scan has made, essentially where the nodule is, how large it is, and how deeply, which is very important, how deeply inside the bowel wall is going. In this particular case, the scan is suggesting what we discussed earlier, which is having roots inside the bowel that we call in medical words muscularis involvement. So one of the deeper layers of the bowel wall has been affected, which means that during the operation, we will certainly attempt the shaving procedure, which is just peeling away the nodule without damaging the bowel. But there is a chance during this operation that we might not be able to remove completely the nodule with the shaving. And that's why when we counsel you in clinic, we will be discussing with you about a bit of a more of a next stage treatment, which is the bowel resection. So during the operation, if we can't remove it with shaving, we will need to remove a little piece of bowel during a bowel resection and joining the bowel together. Obviously, during the operation, when all this assessment happens, you will be sleeping under anesthetics, which means that we need to discuss with you all these different scenarios in a dedicated appointment in clinic, hopefully a few weeks before the surgery, so that you can have the time to process and ask you all the questions that you're worried about.
I think, Valerio, practically speaking, as you know, that even though MRI scan gives us a good idea, but it can underestimate the disease and at times it overestimates the disease. So sometimes discussions goes on even during the operation as well, that what should we do, keeping the principle that minimal is the best one.
Yeah, definitely. As we said earlier, obviously, if there is an opportunity to improve things and to remove the endometriosis with a very conservative surgery, that will always be our preference. We will never do a bowel resection when that can be avoided, because obviously on the potential implication of, what we said earlier, either having infection, risks of surgery, or also preserving the function of the bowel in the future, where we go to the toilet not to
And would you, we talked about doing the sigmoidoscopy intraoperatively after a resection. Would you do that preoperatively?
So we will tend to stratify patients according to different risk factors. When we assess the patients having endometriosis symptoms and surgery for endometriosis, we found that doing a colonoscopy for all patients was first of all quite difficult for patients to tolerate, because the endometriosis makes the bowel quite stuck to the abdominal wall and other organs. So it was a quite difficult test for patients to have. And also because of the young age group and the known disease, very rarely will we find something that will change the management of what we're doing. So, for example, if we have patients where we are worried about other family members having a history of either bowel cancer or condition like Crohn's disease or colitis, we will definitely do some tests like a colonoscopy prior to the surgery, or in patients who have significant problems with diarrhea, losing weight, and we're worried about bowel inflammation. Otherwise, we will prefer to leave the assessment of the bowel and the MRI scan, but also doing these endoscopic tests of the bowel in theater during the surgery when you are under general anesthetics. So obviously we will bypass all the problems with pain and discomfort. So we will tend to have an individualized approach to that.
I'm conscious of time, but I think we'll a little bit go over 8 o'clock, so don't worry about the time. Let me go to Pavlov. Pavlov, she has a right loin pain and also hydronephrosis on the right side. How would you like to approach it pre-operatively before the surgery? And then what will be your philosophy during surgery to manage this problem?
Thank you, Amir, for the question. So having pain and having right-sided hydronephrosis, it is clearly evident that there is a partial obstruction of the right urinary collecting system of kidney to the bladder. If this is neglected and if this proceeds and continues, it can obstruct fully and it can damage inevitably the kidney functionality, meaning that it can severely and massively affect the overall renal function. So having right-sided hydronephrosis, I would definitely suggest to do a CT urogram, firstly to clarify the anatomy of the ureter, the connection of the kidney to the bladder, understand where exactly there is a stenosis. I want to explain what stenosis is for those who don't understand. It's an obstruction, and this obstruction is created from extrinsic factors. It's from the endometriosis that has involved the external tissue of the tube of the ureter, pushing it inwards. After the cystoscopy, the CT urogram, then I will inspect the bladder intraoperatively when we start the joint procedure and have an inspection of the right-sided ureteral orifice, which is the exit of the tube. Insert ICG dye fluorescent contrast to inspect during operation intraoperatively all the anatomy of the distal end and the whole ureter, and safely create a dissecting plane in order to, as you initially said very wisely, just remove what's really necessary without damaging. Only if it is really severely progressed endometriosis, in extremely rare cases, tissue of ureter will be removed. But otherwise, as I initially said in my initial presentation, more than 98%, this right side hydronephrotic blocked kidney will immediately have a patency of the connection and it will come back to normality.
Thank you very much. It was very helpful. And I'll just add one more point, or maybe Maya, you want to add something. She had a 5-centimeter endometrioma as well. Mm-hmm. How do you think endometrioma should be managed in a case, because fertility concerns could be there?
Well, this is a really complex one, isn't it? Because there are, what we're trying to do, the difficulty of removing an endometrium is they can be quite adherent. And therefore, the risk is that we damage some of the underlying ovarian tissue. So there are, depending on the degree, you could deroof, you could perform a true cystectomy and remove it, but risk some damage to underlying tissue. And I guess there the question would be is, her symptoms, how bad, how stuck, the size, and also her fertility wishes. We haven't asked if she's had children, if she wishes children. And I guess I wanted to ask you a question about one thing is preoperative GnRH. Would you use preoperative, downregulate preoperatively in this situation? And also maybe what would you do afterwards if she wanted to have a child or if she didn't want to have a child?
You're absolutely right. It's a very difficult discussion, and one of the most complex part of discussion. So number one, anybody who has a severely deep infiltrating endometriosis with endometrioma, I will always downregulate them. Now, downregulation could be GnRH analog, but we can all use Dymagest and other medical hormonal suppression as well. Number one. Number two, when it comes to endometrioma, we know it now. There's a huge body of evidence. If I do endometrioma excision or cyst stripping from the ovary, it will lead to lesser AMH and also lesser ovarian reserves or follicle in the ovary. So our approach now in the young women who want to conceive and fertility wishes need to be very conservative. So you may have heard, if you go to Google and see it now, alcohol sclerotherapy. I don't want to give a wrong impression because it is not being done in many hospitals. So I don't want everybody to go to their hospital and say that we want to have alcohol sclerotherapy. However, there's enough body of evidence now coming from Europe and other countries now that alcohol sclerotherapy does have a role, leads to minimal damage to the ovarian reserve and also reduces the risk of recurrence. But that is again back to that difficult discussion we need to have individualized with every patient and what should we do. Thank you. Okay, so that's, I think, bring this case just a little bit of perspective for all of you as well. Now, all of you sent a number of questions, and I think we'll try to answer some of these questions and see how far we can get. Otherwise, Dinia very kindly will answer all these questions, and these will be on our website as well for you to go through, because every question is an individual question that helps everyone. So should I start trying maybe earlier than I want to? It's a very generalized question. So anyone with endometriosis, I will say, yes, have a family earlier than later. You leave it late. We know there's an age-related impact, but again, if you leave it longer with endometriosis, everything becomes harder. I was diagnosed with last April. I have growths on my bowel which they wouldn't remove, as I would need a specialist. Can this make me going to the toilet more? Valeria, would you like to?
Yeah, what the endometriosis can do on the bowel is that basically from the outside, as we've seen from the previous presentation, is pushing on the bowel and making the waiting room when we have to go to the toilet, the rectum, feeling the need that you need to go to the toilet more frequently. So one of the symptoms that we see frequently in patients with endometriosis nearby the bowel is what we call changing bowel habit and going to the toilet more frequently. So yes.
Our next question will be, how much of an impact does endometriosis have on fertility? So kind of we've answered it. Endometriosis definitely has an impact. If you ask me numbers, 15% of women will present to us in the clinic with a subfertility or fertility issues in endometriosis and they want having pain. So yes, endometriosis does have an impact on fertility. Then you ask me, does operating or surgery helps with fertility? Then yes, there's a good evidence to show that excision of endometriosis helps with fertility, natural fertility. When it comes to IVF, the numbers don't show the benefit, and it shows that even if you leave the endometriosis and go ahead with the IVF, it does not make any difference to the outcomes. But in natural conception, yes.
So the next question, what are the different symptoms you get with adenomyosis and endometriosis? And I was wondering if I have adenomyosis. So in terms of symptoms, they can be very similar. Adenomyosis tends to cause very much painful periods. It's not a condition that causes the scarring that we see with endometriosis and kind of a chronic pelvic pain or bowel symptoms or urinary symptoms. It really is unique to having painful and heavy periods solely. But it is associated with endometriosis, so you can often see them together. So that's really important to know. And to know if you have it is really based on your history, so your symptoms, but also a good quality, high quality ultrasound scan or MRI is really very good at diagnosing adenomyosis.
Good. Is there a weight limit for excision surgery? There's no weight limit, but there's always a weight limit when it comes to operation. These are high-risk operations, and a full anesthetic pre-operative review needs to be carried out because there could be issues with intubation. So therefore, weight is an important issue which your surgeons will discuss with you depending on your own situation. Is it normal to pass blood clots and mucus?
If the question is vaginally, yes, you can have heavy periods. It's with endometriosis, but just in case the question is rectal bleeding, maybe we can touch on that just in case.
Yeah, again, rectal bleeding is a quite common symptom. Obviously, in clinic, we will check you for other common reasons of rectal bleeding, which are problems of the back passage, like piles, hemorrhoids. And then if we are worried about missing any of the problems, we will do a camera test of the bowel, such as colonoscopy.
Thank you. Next question is, I was diagnosed when I was 18, suffered badly. I'm now 47. How likely is my daughter to suffer with this condition? She's 10 years old. So various studies of population show us actually that this can go in the family. So for example, twins, mom, sisters, aunts can have endometriosis and vagina. I think given that you have this experience, and this experience will be very helpful for your daughter to support her. Not that necessarily she has to have endometriosis, and as already Maya said, not every pain automatically means it will be endometriosis. Anything else you want to add to that?
Yeah, so be reassured because she may not, and she may be absolutely fine, and that's really, really important. And remember, periods initially for many, many, many young girls can be painful. It's where it persists and where things are really severe and impacting her. Given the family history, you can always get her assessed if you have any concerns. it can be hereditary, as Mr. Raza just said, we just answered.
Next question will be, I'm skipping some, we'll come back to some answers later on by writing them. What advice would you give to someone who's trying to get their diagnosis to have more chance of being taken seriously if I go private? No, this is a very, very good question, and thank you for asking this question. Look, go to websites like Endometriosis UK, Health Menstrual Project. There's a wonderful helpline. Before you go to see your GP or a specialist, if you're suffering with pelvic pain, please read those helplines. Write down your diary, write down your history. Do not think you will recall everything when you sit in front of a consultant in that maybe consultation, which could be rushed as well. Write down everything, number one. Number two, with our experience now, we are much better that by your good history, a good examination like bimanual vaginal examination, and a person who is expert in scanning to look for endometriosis, they can diagnose with endometriosis. So if you go along with these things, in your clinic prepared, I'm sure that you can get the result. It does not make any difference. You go private or NHS. There are excellent people in all areas who will be able to help you. Why do doctors misdiagnose endometriosis as a severe period pains for years before diagnosing? How can you improve the diagnosis process for their other patients? You want to add something to it?
Yeah, I think it's a really, really good point, and it's such a cause for frustration for so many patients because they feel not heard, and that's really difficult. I think there's 2 points about that. The first is there's been such leaps and bounds made in terms of diagnostics. It's not perfect in terms of ultrasound, MRI, but we're getting better and better and better. So a good quality ultrasound is very, very good at diagnosing endometriosis. It will not tell you, and again, as I said, a normal scan with a very mobile uterus, even in the context of somebody who has very difficult periods, might not exclude little spots of endometriosis. But actually, the difficulty with little spots of endometriosis, and Mr. Raza is involved in a lot of that research, I'm doing that research at Mary's, is that the treatment, surgical treatment of very superficial mild disease, is that we're not sure how much of a difference that makes to somebody with horrible periods. And that's the challenge that we've got. The other problem, just one other point about how long it takes, is that we don't really know the natural history. Is the first problem horrible periods and over time endometriosis develops, or is it that from day one you had endometriosis? And that's a very difficult question to answer.
Exactly, that's the challenge we all have, that we don't know which one endometriosis will grow much faster and severe, and which it will always stay as a mild disease and the genetic variation. And how is to get the pain, proper pain relief? Why do pain specialists downplay pain? Suggesting is psychological and prevent it from coming back. Let me go back up. I think how to get proper. Pain is a very complex thing. I mean, it has to be, and that's why we are very fortunate to have a very good pain specialist on our team as well, because a difficult area. Pain is a perception of the pathology was inside, and then how the pain is being perception by the brain and by our neurological system is a complex phenomenon. But downplaying, absolutely not. I think the important thing is that pain needs to be understood, the causes need to be discussed in detail, and all steps should be taken to help with the pain. And pain, again, is one thing which then leads to stress, anxiety, depression, psychological, and it all comes down to creating a full support structure around a patient. So hopefully next time when we'll sit in this room, we'll sit with possibly pain specialists, psychologists, psychotherapists, those people to come back to this question in much more detail as well. I think we'll take one more question, then we're coming towards the conclusion as well. I had hysterectomy because of fibroids and endometriosis was also discovered. Having this off, does it prevent it from coming back? I mean, looks like you already had a hysterectomy done, but your ovaries possibly may have left. I don't know how old you are, so I'm afraid I will not be able to say much, but endometriosis is a chronic disease. It can come back. So again, it depends if the ovaries are left and if you're taking any treatment now. So it depends on various factors at this time now. I think I will come toward the conclusion of this session, and I will say thank you everyone for such an engaging and insightful session. We have covered lots of ground today, from the latest research breakthrough from endometriosis to innovative treatment approaches and comprehensive care categories. Our experts have shed lights on the complexity of this condition and provided us with hope and direction for better management and future advancement. And I will also thank you to Cromwell Hospital and its management. They are absolutely phenomenal when it comes to women's care in general and endometriosis care in special. Everything we need to provide the best world-class quality in this hospital, we just get it. And I'm sure by this kind of direct patient interaction, we will learn better how to improve our services and how to interact better. I should also say in the end that this is our first of our series of webinars we'll be doing from Cromwell Hospital. I will be discussing much more complex detailed cases, possibly sharing some surgical videos to show you the detail, and again bringing in pain specialists, psychotherapists, dietitian, nutritionists, physiotherapists, pelvic floor specialists, all of them in this room to discuss various aspects of endometriosis. Just to conclude, let's remember that while endometriosis presents significant challenges, the commitment and collaboration within the medical community and among patients and advocates drive us towards progress. Let's continue to support research, raise awareness, and provide compassionate care for those living with this condition. Thank you again for all of you who have participated and joined us. We have over 500 people signed up and hundreds joined us continuously. So I'm so grateful for all of you to come and join us, and look forward to see you again. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.